Good morning and welcome to our monthly webcast. I am Samir Mehta. This is session number 31 and the 17th since our partnership with the Heart.org. Several announcements this morning. First of all, a very happy new year to you. A very happy new year to our audience in China, and I wish that the year of the dragon will bring joy and prosperity. There are two large groups I would like to welcome onto the webcast today. The VA Hospital in San Juan, Puerto Rico with Dr. Orlando Rodriguez and Dr. Sudhir Vaishnav and his team from Mumbai, India at his new hospital at Leelavati Hospital. This has been an absolutely amazing journey. The CCC monthly webcast with the Heart.org is at the moment being viewed in almost 100 countries with greater than 4,000 people viewing the archives each month. Looks like we have reached almost all parts of the world with one major segment missing, and once I take you to the cath lab, I'll review this amazing and exciting new development with Dr. Sharma. So, without any delay, Samin, good morning to you. You're all set.
All right.
Good morning.
Yes. Good morning.
Do you want to be the first one to announce the new exciting chapter, which is going to begin from session 32 on February the 21st?
Yeah. Actually, clearly that Happy New Year to all rest of the world, including the China, which is the month of Year of Dragon. But key is that we have a lot of requests to translate our CCC live to various languages, and we felt the first one will be to start with the Chinese, so that we expect in February a live webcast will be simultaneously also translated and broadcasted in Chinese, and we have done the groundwork, and of course you with our translator, we have looked into it, and we hope it continues to succeed as good as what we are. As you know that in India we have a lot of our sites, but in India, the English is the major medium, so it's not an issue. Then next level would be probably Spanish and some other translation, but clearly the Chinese has been our big support, and from education point of view, that we will make this is a simultaneous Chinese translation as of next month.
The methodology for this is going to be a three-way process. In the first several months, you'll have a complete simultaneous Chinese translation. We've been testing it out. Hopefully, this will be just around the time for a dinner symposium in the east coast of China. And following that, we'll continue doing simultaneous translation of the slides and also a ticker at the bottom of the screen where you should be able to read the equipment that is being used in Chinese. So, hopefully, this transition will occur, and I think getting 1.3 billion people is important.
Yeah, and actually, you know what? This, although the number of 4,000-5,000 what we get, it's not actually the people watching. People watching could be 10,000. Reason is, as you mentioned, with Vaishnav, with Rodriguez, and many other, it has become the general club. So there may be one computer screen, but there are 10 people or 20 people watching. So there probably will be an actual number of people who watch is much more than what is shown, because that only speaks for the hit to the website, although there could be a more than one, and I'm sure in many places it is more than one person watching it.
Excellent. Samin, you want to take us through the case for today?
Yep, perfect. Knowing that a lot has been said in recent time, with the more complexity, we felt that we show a kind of a run-of-mill case and how you manage in this day and age of our the guidelines and so. Now, this is the patient who presented back to us in August. 77-year-old male with a chest pain and has a small non-STEMI. They did, actually it was outside hospital, they did a stress test which showed inferior apical ischemia, transferred to Mount Sinai, has 3 vessel disease with normal LV function. Culprit was the RCA and got 2 stents. Patient did fine. Our plan was to bring him back for apical LAD because of apical ischemia, but he felt so good, he declined to come back for a stage intervention, which is our common practice in a patient with acute coronary syndrome, STEMI, non-STEMI, that we take care of the culprit lesion, culprit vessel, and bring back the significant lesion later on. But patient did fine and has the risk factors, already have old pacemaker, was in good medical therapy, and which is completely fine. The patients are asymptomatic and they are doing okay. I think it's reasonable to wait and watch, and this basically will show you the angiogram. But what happened basically is that now we start having recurrent symptoms, and the Anu will take us through the angiogram of this particular case, and then we'll talk about what we should be doing in this particular case.
Anu, before you take us through the case, good to know this is your run-of-the-mill case, 3-vessel coronary artery disease, ostium of the right coronary artery, distal left main, and disease in the LAD and the circumflex.
Yes, exactly. Now, I think if you can see the angiogram, I just want to make a point how even groin axis is obtained. My fellow with me is Gautam Reddy, who is here. He got the axis, but the point we teach them and what they follow is they do a micropuncture technique. So they, if you can see the angiogram, that's the picture they take with the catheter first, and what you see very important is the tip of the catheter is actually in the loop of the the iliac artery, and you have to be very careful henceforth how you which wire you advance, and all this condition is that you pull your catheter tip a little backwards, and any kind of either a tiger wire, Terumo with actually you need to have not the straight Terumo, the angle Terumo, you need to use any of these, then make the loop, so that you, when you are making the loop, you keep watching. Many times what you can do in this situation is go subintimal, and without your knowledge go all the way up to the descending portion of the aorta, and then realize you are subintimal. So in this situation he did an excellent job. He used the Terumo wire, went up, put a long sheath, and we were able to get to the coronary arteries.
Yes, which is exactly what my question was going to be. How do you navigate that tortuosity there?
Yeah, we used a Terumo wire and then a JR catheter.
Yeah.
What you do is use a JR catheter, because again the way it is the JR catheter, diagnostic JR catheter, will be able to negotiate all these turns, and once your wire is there, take out the JR catheter and put your long sheath in. And this is the LV gram that which we see here, normal, and then what we see is your right coronary artery stent, which was a Xience, still looks good, patent.
So not only is there tortuosity in the iliofemoral, also in the right coronary
Yes,
artery,
exactly.
Lombard street all over.
And this is what we see is your distal left main and eccentric plaque almost facing the LAD, and you up to 30% or so. Circ essentially is a large vessel which is non-obstructive, but more important
LPL
branch, yeah, small branch there. And then you have your LAD. If you see the ostium, again 17 to 80 right at the ostium of the LAD, and then proximal there is disease mid, segmental, long, and all the way up to the distal LAD. So we can say all three segments of the LAD have long lesions.
So what are you planning, Samin, today for this case?
Well, this is the same. The question is that go after with all the lesions. I mean, more important is the distal lesion in that LAD. If you go back, actually, I think as Anu pointed out, there is ostial proximal lesion. There is a proximal to mid lesion just after the septal, like 2-3 lesions in the mid to distal. At if you see exactly at 12 o'clock and 3 o'clock, then more importantly another about 4 o'clock, another 80% lesion.
Further down.
Further down.
No,
So,
I mean you see two moderate diagonals. Truly speaking, I think the ostium of both the diagonals, the first diagonal, then there are two small diagonals in the mid LAD, and there's one in the distal LAD. All those, I think the ostium are not involved, because the question always comes in this situation that how many side branches are also involved when there is a long segment of disease in the main vessel.
So is IVUS or FFR a part of your strategy today?
Yes.
okay, therefore now we can go back to it. That I think clearly you know that you do the IVUS here, you'll see a significant lesion in the entire vessel.
Yes.
Now then question comes that what data we have. Has the IVUS guided PCI shown to improve any outcomes in a randomized trial? As you remember, in the BMS was some because the optimal stent expansion, and so really in the DES era that not been the case. So that what we know the data is the FFR, that yes, despite angiographically significant lesion, your FFR guided PCI in a multi-lesion, multi-vessel will give you a better outcome by decreasing the stent use, yet not risking patient in terms of having a follow-up MI and so. So this patient now, our goal is today that PCI of multiple LAD lesions guided by FFR, and the now syntax score is 16. It was 22 and 6 was for the RCA, which is very good at present. Now you put in the appropriateness criteria on this particular case, clearly because of the LAD disease and patient has intermediate ischemia, although not on dual antiplatelet therapy, because for the appropriateness point of view, you need two anti-ischemic therapy, which is the calcium blocker, beta blocker, nitrates, or ranolazine. This patient is on one, so that still becomes appropriate because of the proximal LAD involvement, and these are very important. So while we are going to take this case, and I'll go with my speech for 10-12 minutes, we take those technical pearls and issues with the unknown that what will be the points in this particular case. Some of them has already been highlighted.
Yeah, I think I just mentioned about how to evaluate significance of multiple lesions in the main vessel. Either you use a FFR or IVUS, probably FFR better in the most of the situation. And I'm just going to show, yeah, and after, okay, we do. The second point would be, stents. So if we are planning to stent this, if you go, you have to start almost to from the distal LAD all the way to the ostial LAD. We are talking up to 3 stents. And what most important for interventionalists is, do we stent across all the branches, or do we have to protect the branches, knowing that these are moderate size branches without involvement of the ostium. We could just stent across with this third generation DES, so without even the wiring placing any wire in the side branch for any protection. And the third point would be how to tackle the ostial LAD lesion when you stent it, which is the best view that you can use. And do we need situation where you have to place a balloon in the side branch, or a wire in the side branch, which is a circumflex, or we just do the ostial LAD stenting, which we will teach as we are doing the ostial LAD stenting.
Yeah.
I'm just going to show the FFR.
We can just go back to the FFR, knowing that the field of FFR is exploding, but exploding in the sense used to be 0.1, 0.2% in the past, and now it become 4 or 5%, still in single digits. Although at Mount Sinai now we actually using FFR quite more than IVUS, and many of these cases are typical like this, where rather than you putting a full metal jacket, which has its own plus and negative point, that you be more selective in terms of putting a stent, and the overall is still improve the patient outcome and don't risk the patient for the late MI or death.
Samin, before you demonstrate that and show us the value, both of you want to predict what do you expect the FFR to be?
Yeah, very significant. I think the question here always comes, if you put your FFR wire in the distal LAD, we are talking about less than 0.6 or your FFR, and as you come proximal, I think you will start seeing, but even in the ostial, if you bring it up to the ostial LAD, you will have a significant FFR here, which we are talking less than 0.8.
Yeah, I think a very good point. What I would say that I'm calling this vessel as a 4 lesions, and clearly that is on the books. Ostial, then proximal to mid, which is at the septal level, then in this RAO at the level of 2 to 3 p.m. and other one between 4 to 5 p.m. 5 lesions. In my opinion, the lesion 2 and lesion 4 will be significant. Ostial lesion will not be significant, and the lesion of the mid LAD around 2 o'clock, the 2 o'clock position will not be significant. So instead of having a 4 stent, it could be that we may come out with a 2 stents. But let's go with the, we'll see what the prediction will be.
Excellent.
Okay, yeah. So if you can show we have the new FFR, wireless FFR, and the name of the wire is the pressure wire Aries. If you can, yeah, show it here, pressure wire Aries. And this is wireless in the sense normally you have a connection to the machine. So what we say, you can sit in the control room and just think, I'm going to do an FFR, you'll get a number on your monitor. So that's how easy and quick it is. If you show that, yeah, that's exactly. They come, and what you do is you press the button. Now it is sensing for the presence of the wire in the cath lab. So now show here, I'm just going to switch this on. Switch here.
Should be both side by side.
What happened to the other guy? Yeah. Now the other one. Yeah. Now here, I'm just going to switch this on. You see the green light that comes on. Go back to the other place. See now the flashing light has stopped, which means it has recognized the wire is there. Now Pablo Carlos, you show the monitor. They go there. You press FFR. Yeah. You see the FFR, and then on the side you say it is ready for equalize. So what has happened is it's already calibrated, and now it's ready to equalize. Means now I can go with the wire into the coronary artery. When we have in the coronary artery itself, it will equalize, and then you start your adenosine drip. Same thing, adenosine drip, usually you can use a central line. You can have a femoral vein probably to get the best result, or you can use a peripheral line. As you know, you cannot mix adenosine with any other IV. So you need to have a separate IV for adenosine, and our pharmacy right now will mix the adenosine and give it to us. So it's a 90 milligram in a 30 ml, which gives a concentration of 3 milligram per ml, and the dose we use is 140 microgram per kilogram per body weight, and that's the dose we are going to start. And you start once you have crossed all the lesions and you are at the distal portion of the lesion that you want to calculate your FFR.
Anu, you're using a peripheral line or
right now for this patient we have a central line. Okay. To really evaluate, I think you should have a central line, which is a femoral line, and if there is a problem, just put a big venous line, and like I said, you cannot mix it with any other IVs. So you have to have a separate IV ready for that.
Yeah, and this is important with that 4 French sheath. If you put it, and that was done in the trial, but many times we do peripheral, and it takes about 3 minutes to really give you the final answer. And the lastly, just to say that how easy it is become. Now also with the short acting, the new agent, the Lexican, that used during the adenosine, during the nuclear, the STEMI, and so that actually has come back to the coronary. Recent paper in JACC showing that maybe that is the easier way. Just you give an intracoronary bolus injection, short lasting, and it's quite effective. So with that note, while Anu going to put this FFR wire, and once they're there, I'll interrupt my presentation. We go to our presentation, and that the really FFR has become quite user friendly, does not require setup. It's all remote access. So that's a really helpful for becoming user friendly. Just like IVUS is at the control side, you don't have to bring the machine. The same kind of the addition which have been done both by Volcano as well as by St. Jude's. Okay, now we felt while as I mentioned that we will interrupt our presentation once we'll be ready for the advancing now the wire. You want to make just one more comment on the this wire compared to a 0.014 regular hour run through or BMW wire?
Actually, it's not a user friendly wire. We need to you will have to use this torquer to negotiate the tip through any tortuosity or through the lesion itself. So let's see how
Anu,
this
what is the level of user unfriendliness here? As difficult to use as a rotawire, you think?
Probably worse.
Okay, all right.
Yeah. And therefore, it could be okay in a very tough case that you go with the regular wire and
then exchange.
Although it's not exchange length wire. So what you can do is just bring back the exchange catheter, whether it's a fine cross or balloon, into the guide catheter. First you advance your workhorse wire and the exchange catheter, let's say over the wire or with a fine cross, and then you take your wire out, put your FFR wire, and then bring back then bring back the exchange catheter into the aorta. No, just the aorta, that's the only way. But otherwise,
but
many of these cases will be difficult.
Yeah, you won't be able to equalize before the lesion.
Yeah.
So the best thing to do is what you can do, go with your workhorse wire and wire the vessel. So you then side by side you can use your FFR wire. That's probably the best way to do it.
Yeah. Railroad, I think that's the point. Good. While we are making it, you go ahead, and when the time will come to you. Then I'm going to use two important points. One is the recent our practice guidelines for coronary revascularization, which incorporated both the PCI as well as CABG, which case is suitable, and the second is that the syntax score data. There's a lot of controversy at present, or kind of consensus you could say, that that based on the syntax, which patient will benefit in terms of surgical revascularization, and how do you incorporate and implement in your daily practice a kind of a busy lab at Sinai is. The first point, guidelines actually again that American College of Cardiology Foundation, AHA and SCI have come up with these guidelines with the class of recommendation and level of evidence. And this actually published back in November of ACC in a JAC in circulation. And of course, these are the usual things which we all know with the level of evidence A, B, and C, class 1, 2, and 3, and 2A, 2B, and 3 actually say no benefit or harm. And they will actually mention with those in the guidelines that which the particular technique is no benefit or harm. Now, very important that these was a very joint effort of everyone, cardiologist, interventionalist, surgeon, and of course they have a separate guidelines for stable ischemic heart disease or stable CAD you could call, as well as the comprehensive recommendations for all anatomical subset and clinical scenario. Very important, first time in the guidelines it has come. The first time in the guideline is that there is a separate recommendation for revascularization to improve survival and revascularization to improve symptoms. Because very important, in the 86-year-old with a 3-vessel disease, you are not improving the survival of this case. You basically want to make this asymptomatic. So there clearly are the two guidelines that either recommend to improve survival or to improve symptoms, and therefore we need to decide based on the patient, and there is a lot of emphasis given to the patient for that purpose. So we go back to our the slide. So this is a very important point, which is the new for our guidelines, that survival as well as the improve, and the patient is at the center of the decision making. No matter what the recommendations are, that we can tell what patient need to be to the patient, but then patient decide, but approach the patient in a team concept. And of course, various factors influence the decision of the revascularization, being the diabetes, chronic kidney disease, completeness of revascularization, part of, as I mentioned, the young age versus old age, patients who have LV dysfunction, prior bypass surgery, and very important for the PCI point of view, important issue comes, can this patient take long-term dual antiplatelet therapy, because many of these complex lesions will require DES, so you need to give it at least for 1 year. So this is a major issue clearly in the decision-making process that whether patient can take a long-term antiplatelet therapy. Do you want to see it now? Should we come back to you? I think this is a very important one. If we can stop here and show the angiogram, and you can see there that and we can show the screen. Yeah.
Anu, how difficult was it to navigate the wire?
Yeah, it was okay.
Make it a split screen of the both.
Yeah. Can you? Yeah. So we are not even crossed the distal lesion.
Yeah.
Without adenosine, we not even cross the distal lesion is very significant.
Right.
Yeah, some die. So I know I'm in the lumen. Okay, good.
Yeah, this is where will be the little tricky, and
having pain.
We are not even started. The adenosine. Now you are in a small branch.
I think I'll let go there. You see now getting into the main vessel is okay. Now I'm in the main vessel. What I am trying to show you the same is that without the torquer, this is the only time I think I use torquer is when you use this FFR wire. To make sure you are in the lumen, and then your wire introducer has to be out. You have FFR without hyperemia of 0.60. Now you start the adenosine. So it may take up to between 30 seconds to 45 seconds to see some maximum hyperemia when you're giving it through the central line. You started it? Start, yeah. Yeah, start. Now start the timer. Okay, you see the timer now.
But this is already significant. Do you still have to do it? We don't need
I mean, you have to do the pullback,
Yeah.
but wait a little bit so that we know if it goes really low.
And show the, our fluoro screen on the side, the split screen. Good.
Good. No, we have to wait for my hyperemia when we are doing the proximal. Did it go low?
About the same, if anything, just creeped a little higher maybe, 66, 65. Samin, between the St. Jude and
now
the
you
volcano.
start, now see,
Yeah.
I said like 45 seconds
0.5.
or so, it's points, yeah, it's going to start pulling back now. So,
I think they had made a lot of changes in the volcano also.
so now
but
this is in the mid to distal lesion. We are about 0.58. The drip is going.
Which system are you
This
using
is
more
the
at Mount Sinai?
proximal.
yeah, we actually using the St. Jude's,
And then-
the ready one.
We come to the ostium. It is
Patient having symptoms?
yeah, it's a point 70.
Yeah. Good. Yeah.
Okay,
Have
good.
you ever Anu had any situation where there was any closure of the vessel with the wire? You had difficulty getting back with the wires?
I mean, in the last 2 years, I think we have done probably more than
Stop.
500. Yeah, stop the adenosine. Other also, I think a lot of the time symptoms could be due to adenosine itself.
Right.
Yeah, they can get a brady. This guy has a pacemaker, so we don't have to worry. But there's been one situation in the lab where it was the vessel transit closure with the FFR wire, but otherwise had no problem. But what we often see is what this patient is experiencing can have chest pain because we have gone through the multiple lesions or side effect of adenosine itself. As soon as you stop, I think in 30 seconds it disappears.
And more
Better?
importantly, what
Yeah,
we are
we
going to do in
stopped
this case, that we'll do a 2 stents, one in that periseptal and one at 8 o'clock, the 3, 4 o'clock position, and then we do the FFR. That will tell us exactly what is the contribution of the mid LAD lesion and what is for the ostial LAD lesion. Okay, and you go ahead and do this one while I'm going through our presentation. So now, basically, as I mentioned, key decision point, that very important also, that can you do a complete revascularization, and as I mentioned, the issue about the dual antiplatelet therapy or patient has a comorbid condition, and very important, as I mentioned, that they made this, that what does the patient want? No matter what the data are derived from group of patients, patient may decide, you know what, I can come back 10 times, as long as I'm not going to die, that's okay with me. So clearly, so the ultimate decision comes with the patient, and so. Now, few things have come into equation. Basically, as we know, for the diabetes point of view, that patient, these are the multiple trials of the diabetes showing that in a diabetic patient in terms of mortality, the curve is favoring the CABG. Of course, many of the trials do not pan out, and of course, we know the Freedom trial, which has completed and expected to be will be presented in European Society of Cardiology this year, will be the final answer for the multivessel patient diabetic, what is the right approach, DES versus coronary artery bypass surgery. Lot emphasis has been done in the trial, in the guidelines based on the Syntax trial. Why? Because this probably is the only trial which has incorporated your various clinical and anatomical situation and then make a decision what is right for the patient. And of course, now we have the 4-year follow-up of these patients, 90+%, which were presented in a TCT last year. Now, of course, various group of patients, the left main with 1 vessel, 3 vessel, and so all have been shown here. That the 3 vessel alone was about 2/3, and 1/3 was left main along with 1, 2, and 3 vessel disease. Now, these are the data of up to 4 years, and you can see here that if you take the all-cause death, again, it is a slightly lower, 8.8 versus 11.7, the 3%, 2.9% lower in the CABG group compared to Texas DES.
Right?
Now, once you go to myocardial infarction, actually the difference which we knew that at 1 year was just making trend, but it starts showing a significant trend after 1 year in second, third, and 4th year. And we know why, because of restenosis and some cases of late stent thrombosis, and so presenting as a myocardial infarction. The CVA, at least that's a little relief for the interventionalist, that clearly we have a lower even CVA even later, although it becomes less significant at follow-up at 4 years. As you remember, in 1 year, there was a significant difference in favor of PCI, but at follow-up, CVA no longer become, or just a trend, and no longer the statistical significant. So you combine this three major, DES, CVA and MI, to 4 years, about 4% advantage of the CABG versus Texas DES with a p-value of 0.07, so the trend. So the hard endpoint still remain trend as a overall in the trial of these complex cases. The revascularization, clearly we know that all right from the beginning is in favor of the CABG compared to PCI, and if you combine those MACCE up to 4 years, significantly lower in the CABG group compared to the Texas DES. And of course we know there was a syntax score developed in the trial, and really the outcome was based on the various syntax score tercile, and idea was to select, we knew before the trial that both technique will be probably equal in many of the scenario, but which scenario one technique is better than other, and that was one of the guidelines we got from the various syntax score. And of course the syntax heavily based or weight on the CTOs and bifurcation. Why? Because those are the ones do badly with the PCI, higher event rate and higher complication rate. Now this actually is the important point now. Now I am going to show you the data of the overall trial and the 3 vessel disease data which were presented based on the a 4 year MACCE in the low score, intermediate score and high score. Yeah, clearly the patient is having a chest pain with this. We are going to give a little extra medication. Yep. Therefore, let me just settle down the patient a little bit. Dilate here. The multiple, the PCI is being done of the various lesions. Yeah. So now, I think just merely putting a wire has created a lot of chest pain onto this patient.
Okay.
Good. Let's pull back. Give a lot of nitro. Good. Good. You need nitro.
Okay, sir.
Okay. Nitro, verapamil
Yeah,
anyway.
Good. We give all of those.
Yeah. Good.
Question is, do we give a gap or stent across?
No, but you go distal stent now.
Done.
Now patient is a little better, no, stent wise.
No.
Get a little verapamil. Yeah. There you put a long lesion. Yeah.
There's an intermediate. No, in between. There's no. See that?
Yeah, that we can do later. That was the plan. We'll do the IVUS of the 2-3 that lesion between 2 to 3 o'clock later on with the FFR guidance. Right? We're putting a 1 clear-cut stent in the distal LAD, 1 stent at the level of the septal, and then we make a decision of the ostial and truly that mid to distal LAD segment.
By repeating the FFR.
By repeating the FFR.
Get us a long stent then, right?
Yeah, distal first. Okay, so now patient is a little settled, clearly very ischemic. So let's just come back to our angiogram quickly. That basically in the low syntax score, as you can see, the Texas and if you take MACCE on the left side and individual component, that you can see the death, but the CV of course is in favor of the PCI because it's lower, and even the death is a little lower, myocardial infarction non-significant, and of course the revascularization still remain in favor of the CABG. So you can make it a point in overall, in a overall group of the low syntax score, that PCI in all way as good as CABG with a significantly lower CVA. Now if you take a 3 vessel disease and you clearly the same answer basically you get in the low score syntax patient. Now you go to the intermediate, which is 23 to 32. Now you can see here that there is no difference in the death. Clearly the difference, there is no difference in the CVA. There is definitely a difference in the myocardial infarction and of course the revascularization. So clearly now you start seeing that in an overall group some benefit of the CABG over the drug-eluting stent, the Texas. But once you go to, this is both involving the 1/3 left main and 3 vessel, but you go to this intermediate score in the 3 vessel disease, the data are here. You see the significant lower mortality of the CABG over PCI. And of course, there's significant difference in terms of the myocardial infarction and so. So that clearly now the guidelines are trying to incorporate that yes, even in the intermediate score with a 3-vessel disease, not in the left main or 2-vessel or so, 3-vessel disease, it can make it a point of doing a CABG rather than doing a PCI. Now you go to high score, which was very clear that overall that you have a lower mortality with the CABG, lower myocardial infarction, and of course the combined endpoints. And then if you go to the 3-vessel disease, similar data. So the one thing became very clear that high syntax score in all cases, and more importantly the intermediate syntax score in intermediate the syntax score of 23 and 32 in 3-vessel disease favored coronary artery bypass surgery. And therefore then question comes, what is the recommendation? Recommendation basically is that you need to present these data to the patient. The patients with the unprotected left main or complex CAD, which is the high intermediate to high syntax score, is reasonable to have a hard team approach, and that is a class 1 indication, and that's a very important. That basically hard team approach these patients, you provide the data what we have based on our diabetic data from the cardiac trial, and more importantly from the syntax, that the combined decision. So these cases cannot have an ad hoc PCI. The hard team approach of complexity calculation of the STS as well as the syntax score is very important for following the guidelines at present. Now, then in unprotected left main, the revascularization to improve survival, that clearly the CABG being a number class 1, and of course found that 2A, the patient with stable CAD, syntax score is less than 22, or those who have a high increased CABG risk with a STS mortality of more than 5. So those basically patients have a 2A. Now 2B, that where PCI complications are low and your syntax score of between 22 and 33, and your risk of CABG are slightly higher, not extremely higher 5, but about more than 2. So this basically is a new guideline improvement. So that now we have the unprotected left main guideline suggesting that PCI is a 2A in a high risk, the high risk STS cases with intermediate syntax score, and then clearly 2B in a patient with a mildly decreased STS mortality. And of course, if it is the complexity from the PCI point of view, and it's a suitable case for CABG, not a much comorbid condition, they're ideal for coronary artery bypass surgery. And of course, with unstable angina and STEMI, the PCI is class 2A. So now, what about the individual subgroups of the multivessel CAD? Clearly, the 3-vessel CAD with the proximal LAD is still they highly favor the CABG, as we know, because the PCI has not shown to improve survival any of those scenarios, whether 3-vessel disease, 2-vessel disease, with or without LAD. Clearly, what has been shown also that if you have a coronary anatomy disease, but you do not have a functional physiological criteria for revascularization, doing a PCI or CABG is harmful. So that clearly you need to have and particularly if you exclude the proximal LAD. So the 1-vessel disease without proximal LAD or no anatomic or physiological criteria for revascularization, doing a CABG or PCI is class 3 harmful. So we need to be careful. So many of these cases have a little bit of CT angio, comes to the cath lab. You need to document by the IVUS or by FFR that where we are in terms of the significance of the lesion, and then the only patient should undergo revascularization. Now, then the improved survival, I mentioned the particular subgroups now, basically that the patients with the LV dysfunction, again, the favored with the 2B in the CABG group, but we have very little data. Also very important that patients who survive the sudden death, that patient should get cath, and based on the appropriate anatomy, CABG and PCI is indicated. Now, then clearly, as I mentioned here, that this basically speaks for whether it should be a CABG or should be PCI in these complex cases. And basically what the guidelines are, that 2A for syntax score of less than 22, and those patients who can get a Lima is the recommendation of getting a PCI. But more than 22, and this is what the guidelines now in 3 and 4, that CABG is recommended in these complex cases. Now, what about the symptoms? I mean, symptoms is a little simpler. that clearly if you have significant lesion and you have the guidance directed medical therapy, the guideline directed medical therapy, you still have symptoms or ischemia, those patients should undergo revascularization, and those has been shown to be beneficial. And again, that if there is no anatomic or physiological criteria for revascularization, it's a class 3 doing any of those revascularization. Now, hybrid, of course, we use it in some cases. Now, what about the specific guideline for the PCI? The PCI basically has gone into is that basically the 3 different points. One, what is the risk of PCI? Second, what is the surgical risk? And third is, what is the likelihood of the long-term durability? And of course, as I mentioned, the syntax has come heavily into this equation, and this is a very nice grid, which really speaks for that from the harm to the benefit on the top, that if the PCI can be done safely with a syntax score of less than 22 in this complex disease, that it's a 2A indication, and of course in the 2B, only it's the cases where there is a high syntax SDS mortality. And of course, same way in terms of the symptom improvement in the individual coronary artery disease shown here. Coming back to the various medication which we do all the time, very important that they have now incorporated statins as a 2A, that patients getting PCI, and of course that will be part of the Excel trial, that all patients should get the statin, high dose statin if they are naive, or otherwise just a moderate dose before your PCI. And of course, lot issue about the ethical consideration that our decision should be made based on the overall patient scenario, not based on any reimbursement or personal gain. Now, radiation, they actually have a very important point of that every case should have radiation exposure and so. So quickly coming back to the how do you implement this? This basically what we have done, if you put a 4-year outcome data of the intermediate score or high score with the individual endpoint, we have created this document, and which is available now, will be on the website, anybody can download, that incorporated the syntax score of 23 and above with patients if do not make the criteria that surgery is not a clear-cut class 1 indication, and the PCI is okay, like patient with acute MI, class 4 angina with a well-defined culprit lesion for PCI, old age less than 80 years, more than 80 years of age, prior CVA, severe COPD, BMI more than 50, EF less than 30, and in the trial that these cases probably would not go for CABG, so that those cases can, even with a high syntax score, you may decide to do PCI. But if it is not fall into these categories, patient has to come out and has to have a discussion with a hard team approach, and then patient can come back for the PCI with a clear decision making, patient being at the cornerstone. And now only issue remain is that yes, we are making all these guidelines and our change of practice based on the data from the Texas DES. We all know Texas DES was inferior to every trial done against everlumus eluting stent in the SPRIT and compare and so. But this is what we have. Now, if you can extrapolate the data of the everlumus eluting stent into this curve and the CABG being in the blue, I can tell you that it will be exactly as a CABG. But that's no answer to the problem, because we had to have a guidance based what is available at present, and it seems to be that we still have to follow these guidelines. Now, these things will change because some of the trials are oncoming, and we learned that with this particular case with the multivessel disease, that you do just the PCI FFR guided, that you still do quite well. And many times these patients after the FFR, you can change them from 3-vessel, 2-vessel disease to a single vessel and don't require intervention in many of those lesions. Now then the question comes is that what is the correlation of the FFR versus the lesion severity? This is shown that once you have very tight lesion, very rarely your FFR will be more than 0.8. Once you go to the medium lesions, that's where you lose the really predictability of your FFR, and many of these cases, half of them could have a FFR of more than 0.8, even if angiographically looks like 60–70%. Of course, there is a FAME2 trial. This is actually extreme, that these patients will all have FFR of 0.8. Now question is, even in FFR of 0.8, that yes, the FAME trial one showed that doing a PCI good, but what if you do a good medical therapy? And this is the trial ongoing, FAME2 design, which may change our the guidelines in the future. Another trial which I mentioned, Freedom, which will be a 3-year endpoint, will be presented later this year, XL for the left main, and these are the very, very important trial which will change the guidelines in coming year. Another very exciting trial of the ischemia, the kind of courage, but implemented before coming to the cath lab. And of course, you exclude the patients with no disease or left main by the blinded coronary CTA. And this is again 5,000 plus patient trial, will take about probably 5 years, and those will be randomized to invasive strategy or optimal medical therapy, but before the cath. And that is the important point, that these all will be done before the cath. And so now, Anu, you update us where you are in this particular case.
So we dilated and put one stent in the distal area. The question was same, could we have given a gap? I think once we did a balloon dilatation, looked like we needed to take care of the entire, see that from the mid to distal. Some of it is wire bias, but the question would be same if you put a short stent in the distal LAD and leaving a 10 millimeter gap would make it even worse. So we just decided to put one long stent, that is a 2.5 38 millimeter stent, which has been done, and right now we are waiting what would be the decision for the mid LAD and proximal LAD.
Anu,
we have
you mentioned a 2.5?
No, we have a, no, we don't, it's a yeah, 3.38.
Yeah, but I think based on this, it's a reasonable to put a stent in the proximal area, right?
Yeah,
See,
up to the ostial.
where's the last picture?
This the last picture now.
Anu, you said this is 38 millimeter, what size?
2.5 38, and then we post dilated with a 2.75 up to 18 atmospheres.
Right, I was surprised. It definitely looked a bigger vessel than a 2.5 there, but
it's a 2.75. Now they're ready with the 3.0
in the midsection.
Yeah, in the midsection, yes.
Yeah.
You're going to pre-dilate that or go direct stenting?
We have pre-dilated with the 2.5, and same, I think 38 stent was not that easy to deliver, but it was okay. We didn't need a double wire or anything. Was still
Which stent did you use? Is that the Ion?
The Xience Prime.
Okay.
Now, what if now Anu, you put this stent from the ostial LAD covering the proximal and leave the mid, and that we want to see based on the FFR. That's what the whole discussion is.
Yeah,
right, because that lesion angiographically you would tend to stent that part,
right,
no?
But that is what we need to prove.
Okay.
That is that a true statement? Because we can always put a second stent later. I mean third stent. So let's do the second stent now. Go.
I think you need to cover.
Yeah, but no, we know. But remember, that is what, believe me,
Why don't we do
in
the
a
proximal, I mean LAD later on? We will have to.
No, but put this one, because we have the septal lesion we need to cover. The reason is, this is exactly, you saw it, that about 4% of cases, even with the angiographically 90% lesion, had FFR of more than 0.8. So that, and this we are talking about the, not a 90% lesion, about 80% lesion, where the FFR lost its charm in about 18% of cases and so. So I think it will be reasonable, because that is the point we are trying to make. Let's cover the ostium and make your point that do you want to put a wire in the circumflex or no?
So Anu, just keeping it a little more coaxial and you were able to advance the stent easily.
Yes, yeah.
Which is what I heard you teach your fellow Gotham before the case.
That lesion will do later. That is based on the FFR. Yeah, no, we know that.
We dilated it already.
Yeah, that's fine.
Okay,
so
Samin, so from what I am kind of tending to read between your lips is that you think the mid lesion will not need to be done.
Right.
Okay.
Yeah, that is exactly the point will be, right? Because, but now the question, make it a point that do you want to put a wire in the circumflex for the regular operator?
I think first going to the view that you want to select to go to the ostial LAD caudal, either LAO caudal, AP caudal or RAO caudal, whichever one where you see the ostium very well.
You know, for years I used to be the LAO caudal person. Now I've moved a lot more to the AP and the RAO caudals.
Exactly, because point is the LAO caudal always, because the diaphragm attenuation is very grainy.
And less radiation, I think.
Of course, and the radiation issue. Yes. Point is, the regular operator should put a wire into the circumflex or no? That's the point you need to make.
Let me just make sure that we are covering here.
So
what is the harm in putting a wire into the, knowing there is a mild distal left main, and which we can always do IVUS and human cross-section area later?
Maybe a overkill. I think this is relatively straightforward.
Okay.
Yeah.
All right.
I think if you can see where exactly you see where the stent starts, just where the dot is, you are covering the ostium of the LAD.
So with this, there is absolutely no disparity between the marker and the beginning of the stent.
Yeah.
Yeah. And compared to both ion and the PROMUS element, your stent starts at the distal end of the marker.
Right.
And here is a kind of in the first 1/3 of the marker.
But I would still say, I think train your eyes to look at the where the stent starts rather than the marker, since the different stents have different strategies.
Yeah.
So you will never miss the ostium.
Go.
Rather than looking, oh, it came back again. Some dye, give some dye. Good. Yeah.
And the patient has been tolerating
Yeah,
this,
tolerating
no problem
the-
at all.
yeah, good.
Okay.
Yeah, I think that distal lesion was very significant. I'm going up now.
Okay.
This
Now
is
another point also, if you see here, what we say is bring your shutters in.
Yeah.
It's a very important point for interventionalists who are doing a lot of cases, so that your amount of radiation definitely goes down with the shutters.
No, none of your cath labs has the stent boost systems.
Yeah, we have it. Yeah, with this
Do,
one.
do you use it often?
Not me.
Okay.
I use quite a bit.
All right. Good to have
Yeah.
a slight difference in
Yeah.
techniques and
Yeah.
feelings. I think that only adds to the
Yeah, in this
knowledge
case,
the fellows will get.
absolutely. In this particular case, because the pacemaker, you'll have a lot of artifact of the stent boost, unless you really cone down. So any dark shadow, radio opaque material, the shadow will create a problem, even if you leave a balloon. And we actually can make it a point here.
And now this is this 38 millimeter stent, so you just have to be careful when you're taking your balloon out.
You always withdraw the guide because it
Very-
keeps
see
getting
the guide.
sucked in. So angiographically, I am telling you, it is going to be clear that people would want to put in a
Yeah,
third
it will
stent.
be a stent. Yeah.
Yeah. So let's see now, and
Let's,
I don't know how
just,
much.
let's make sure our ostial is well covered if you have to post dilate or do anything.
There are days I wonder how much are the stent companies loving FFR. You happy with the proximal and the ostial looks all right there in that
We need to
view?
post dilate. Yeah,
We
yeah.
need to
very-
post dilate. Yeah. Go to the mid portion now.
Yep. Yeah, you want to post dilate with a 3.25 or 20 high pressure? That you are going to do. Okay, on floor. Okay, I'm going to put a little bit of ml. Good.
So I mean, at this moment, okay.
It's a dissection. What do you want to do FFR?
Well, angiographically, the mid segment looks not
Yeah,
too bad.
Because, well, I mean, the
No, that's
point is
a-
part of that has been dilated also.
Right.
What happened to the wire? Put it away.
It's not working, I think.
Yeah.
Let's just extend it. We will have the dissection there.
Yeah.
Environment
Now,
has
only
made
question
problem.
is, in this particular case, I probably would agree, reason is that they apparently dilated that mid segment because of patient having chest pain. Once you see a little dissection, see that? At the level of that diagonal at 130 o'clock position, I think it's probably better now to just put a stent, and that theory will remain theory for maybe for the future use and prediction. So put a new one. You
So
can put a
28 millimeter
yeah,
3.0.
23.
Yeah, 28. 28 will be okay.
I thought
Yeah.
28. It's a longer
Go through your
segment.
28, yeah. Cover that completely, and then we'll post dilate.
In your mind, Samin, how do you calibrate? How much do you think?
Yeah. Yeah, I'm sorry, what?
In your mind, how much do you think is really, how much gap has been narrowed between the benefits of CABG in 3-vessel and unprotected left main with the availability of third generation DES?
Well, that's the problem that it seems to be, yes, if we extrapolate the data, but the problem is that, that we don't have that answer at all. And maybe, and that is what, if you remember, if you go back to the up to intermediate risk score of the unprotected left main from 0 to 32, actually the mortality tended towards lower in the PCI group than CABG, just only if you take the unprotected left main group. So therefore, having said that, I would say that even with the old stents, that it favored in the intermediate risk. Now, as I showed that the overlap of that, that overlap of that curve, that basically that overlap in this particular case, if you extrapolate the data of the everolimus eluting stent, and similar now we know with the Resolute in terms of the revascularization point of view, although that has a slightly higher stent thrombosis, but clearly that those difference would have been or trial results would have been different. Okay, yeah, we are going up now, and tell what stent this is.
So 3 or 28.
Okay. The 3 or 28 Xience, again 12 to 14 atmosphere only if you require to post dilate, although here is less of an issue because stent is within the other stent, and it's a 14 atmosphere. We do a 2 quick inflation so that a more circular expansion of the stent, and leaving for few seconds. In sometimes that you may need to leave with a long stent, a little longer. We have seen it to the 30 seconds and so, and so that for a good stent expansion. But they have an issue of the deflation and the balloon sticking, so they make sure that your guide is removed from the ostium.
Anu, bivalirudin use here?
Yes. We have a bilevel with the ACT of 320.
Okay.
Now what about 2B3A in this particular case, who is not at risk of bleeding, and now there are multiple branches. I'm sure even with the second, or now actually you can call Xience Prime as a 3rd generation stent, that clearly you have the high pressure balloon. That you'll some of the branches will be compromised. That in this particular case with the multiple stents, although patient was already on clopidogrel, but for the side branch issue, I personally will give 2 boluses of aptofibatide.
Wow.
I know that Anu is on the lower 2B3A use. I use the 2B3A in about 15-18% of cases.
So you lean back onto the data from the EPIC trial on that with
the
side
exactly.
branches.
For the side branch point of view, it still remains that many of these side branch symptoms are because of just a plaque and shift, and some of them is just platelet mediated, and so that by giving 2B3A, you take care of those the snowplow effect in these branches.
What is your overall use of 2B3A?
Yeah, about overall, I would say in our lab is like low teens, and I'm around 8. I'm probably the highest user. Guide me a little more in. I'm probably about highest user of 18 to 20%.
You attribute that to your probably
Complexity.
more complex cases. Yeah. Okay. And between the two, which are you using equally?
Well, actually, abciximab only now selectively for STEMI patients. We do not use in a non-STEMI patient, so that if we our 14-15% of 2B3A use, this is 14 atmosphere. It's a 90% aptofibatide and 10% abciximab. All boluses, abciximab single bolus and aptofibatide 2 boluses, 10 minutes apart, and many of the cases we have just given 1. And particularly patient has a complex disease, and we preloaded patient on the table with the clopidogrel. Now, if you give prasugrel or for that matter maybe even ticagrelor,
3.5.
yeah, which atmosphere?
10 is good.
Good. Yeah, then clearly it's a 3.5, 20 quantum apex.
Down.
Yeah, the non-compliant quantum apex, and you have to bring in this kind of long lesion cases, the post dilatation, because many area, if you do your stent boost, you will see many of these areas have not been expanded.
Well,
now,
also I think it's a good idea to expand the overlapping segments also.
Yeah. No, not overlap.
100%.
Yeah.
28.
Okay, now you want to go to the caudal view?
Yeah.
For the ostial coverage. Yep.
Okay, now you go.
Okay, now clearly you have to be careful that you are 18.
Okay, down.
Now here you want to do the stent boost quickly. They are so far patient tolerating procedure quite well. the floor. Not. Okay, go.
There's a very interesting question which has come up.
Yes.
How are you teaching your fellows? How rigidly are they following the appropriateness criteria? Every case, documenting it?
100% every case.
Every case. And not only that, as you know, the major issue now is many of the insurance companies are incorporating even before approving the patient for cath possible PCI. Now put the balloon back in. Let's see the stent expansion on the stent boost since we have this chance. No, but we may not be able to see the stent boost there. Right? Okay.
You can see it without the balloon?
No, we have to have balloon. Otherwise you will not see the stent boost. Yeah, this may be okay. No, bring it. Yeah, good. Good, that's fine. Good, good. Now bring the screen. Anyway, we are going to stent boost, and then we'll see. Yeah. Okay. Yeah. Turn this. So you're going to see it there. Why did not do? Huh? Stent boost. Okay, 1 second.
Presence of that valve.
Cardiac special. Okay, just 1 second. Right. Could not do this simple thing. Okay. Now we are going to do the stent boost now. Cardiac special. Okay. Try to show this of the screen. Yeah. Yeah. Can we show that?
Yeah, okay. See
Yeah.
the picture now. Very nice.
Very nice. So it looks like ostium L also has expanded well.
Right.
And now we just have to see where we are in a better angiographic picture. Good. Turn it back towards us. And we are reaching to our time also.
I still think it's a fairly decent poor man's IVUS.
Yeah, oh, absolutely. Absolutely. Now clearly that all these new programs nowadays, they actually have another called the stent boost subtraction. So that when you give a dye even, it will give you outline of the stent itself. Therefore, rather than just seeing the stent, you will see the lumen. That's the latest program which we are trying to get in our new updated lab.
Ostium looks good there, Anu.
Yes.
Yeah. You see it now
Looks very nice.
without pinch of the circ.
You want to get us another picture in the REO to see the mid segments?
Yeah, we'll see that.
But short of not going back to decide on the mid segment with the pressure wire, I think this is otherwise an outstanding.
Yeah, I think this is the kind of case. Some cases will be that you have to just stand throughout.
Right,
And
looks
yeah,
outstanding,
now see that,
outstanding result. Yeah.
Exactly. Now the septal, the medium-sized septal has a little bit of a pinch at the ostium.
But the
And
flow is excellent.
Yeah, this is the kind of case I definitely will incline rather than going and change it through the stent struts. That just put a give a 2B3A, that liquid stent, the 2 bolus of the aptophebatite, and like if you go back now, and this is very important, you have to be careful that this is not your overlap area. See this here? Yeah. Okay. See, until now it is good. See that? Your stent is distal. Very simple. Clearly, when you want to protect the branch, make sure you do not put the stent overlap at that branch. And here, we are very careful. One stent distal, left that medium-sized diagonal, others are small. And therefore, once you put a second stent, that area of the diagonal was not overlapped, and so that it's make a tough decision sometimes. But clearly, that by giving a liquid, I would say 2B3A will answer this, will take care of this patient is not having any chest pain, sleeping well, and we come back to our last 2 take-home messages. Now listen to this one now. We've taken a picture. Now the one is very important, that the heart team approach of the interventionalist, the CT surgeon, and the cardiologist is needed to make the optimal recommendation for advanced complex stable CAD. Now choice to be made with consideration to improve survival versus improve symptom in a particular patient, and patient choice will ultimately prevail. Very, very important. We can present the data, but now question always comes, what do you call as advanced complex stable CAD? I would say distal left main, any distal left main, or the syntax score of 22 and above. So those are the advanced in the CAD. In acute coronary syndrome, it's a 2A. There you can go ahead and do the culprit vessel, whether it's a non-STEMI or STEMI patient. Now second, the physiological FFR guided selective PCI of significant lesions in presence of multi-lesions may help to limit stent usage, yet improve long-term outcomes without causing any harm. This particular case, of course, we want to practice as much as possible. We could not do because of the little dissection in the middle. If you have done the PTCA, clearly do that area you should then in these kind of moderate lesion. If you have done a PTCA, you should stent it, because PTCA will have a very high restenosis. They actually have presented the data of the FAME trial follow-up, that what was the contribution of the out or event for the lesions which were left and did not have a PCI based on the FFR. And the number was 1%, one case. So clearly that 1% of cases, the less than 1% of cases had a bad outcome related to lesion left based on the FFR. The most of the outcomes are because of restenosis or progression of the lesion and so. So very important that if your FFR is more than 0.8, you can take the ease breath and leave that lesion. Do not worry. But what happened in this particular case, in order to get the stent distally, we have to dilate that lesion. That case, then you had to put a stent, even if it's a full metal jacket, but that is what required for having a good outcome. Anu?
Anu, any final thoughts from you? In the meantime, I am happy to report that our second mock test of the translation went exceedingly well.
Yeah, I think the patient actually responded well, not having chest pain right now, quiet, maybe despite multiple stents. Now the question also comes in this situation that he's a young guy. Do we continue with the three long stents, and he has 2 stents in the RCA. Any thoughts about changing his antiplatelet therapy to the newer agents rather than continue him on Plavix?
Yeah, I think that's a very important point, that what I would do based on what we learned, that if you do before giving 2B3A, check for platelet testing. If your PRU is less than 208, I would say you are fully covered, even on clopidogrel. If it is not, and knowing that his age is 77, he is not a good case for prasugrel. So in this particular case, then you give ticagrelor 180 milligram and the 90 milligram twice a day.
Sounds a good management plan. Sameen, there's another announcement I don't know if you would like to make about your starting the peripheral interventions program here.
Yes, we actually putting together that there will be fourth Wednesday. Fourth Wednesday.
January 25th is the first one coming up.
Exactly. On 25th will be the first, just duplicating the same model and the success of our CCC Live, that for endovascular live with the Prakash Krishnan and Jose Wiley and the George Dangus will be the moderator, and the concept will be the same way, that present the case, slides and performance of the patient, the case, because we got a lot of requests to do structural heart disease and peripheral cases, so that hopefully in 6 months or so we'll add the performing the structural heart disease, particularly the TAVI and mitral clip cases. But with that note, we definitely adding another educational armamentarium from Mount Sinai to those based on their individual specialty, and will be, I'm sure, it will be as good as an educational tool what we have done for our CCC Live.
At this moment, we'll conclude our session. Please join us in the session number 32, which is February the 21st, and hopefully we'll even be doing a simulcast in Chinese. I hope you found it useful, and a very happy New Year to you all again.